Our next speaker is Professor Tarek Abdel Barr, as we know him very well. He's an eminent professor of anesthesia, Cairo University. He is a chairman of OB-GYN department, University Kasr Aini Hospital, and he is a former researcher in Leiden University Medical Center. And he will highlight and present for us one of the nightmares of anesthesia. He will discuss the issue of placenta accreta. Hello, Dr. Tarek. Welcome. Mike is with you.
I would like to thank Dr. Saad for his tremendous efforts to bring these lectures into light. My talk tonight is on the anesthetic management of placenta accreta. This lecture is just a clinical approach in the management of the abnormally implanted placenta. All cases are done in the obstetrics department in the Faculty of Medicine, Cairo University. First of all, I would like to define what's placenta accreta. Placenta accreta is defined as abnormal trophoblast invasion of parts or all of the placenta into the myometrium of the uterine wall. Placenta accreta spectrum, formerly known as morbidly adherent placenta, refers to the range of pathologic adherence of the placenta and includes placenta increta, placenta percreta, and placenta accreta. Let's talk first about the incidence of and the risk factors of placenta accreta. Rates of placenta accreta spectrum are increasing. Observational studies from the 70s and 80s describe the prevalence of placenta accreta as between 1 to 2,500 and 1 to 4,000, compared with the rate of 1 to 533 from 1982 to 2002. I mean, 2 decades. And thanks to the ultrasound that showed us the abnormally implanted placenta. There are several risk factors that result in placenta accreta. The commonest is a previous cesarean section and is increasing with the number of prior C deliveries. Though we found that placenta accreta happened just on the second time of cesarean section. Placenta previa is another risk factor. Additional risk factors include advanced maternal age, multiparity, prior uterine surgeries, or curettage. The relevant considerations for case optimization in planned placenta accreta spectrum, this starts in the preoperative period. We have to maximize the preoperative hemoglobin values. Verification of specific timing of planned surgery. Identification of exact location of delivery. Verification that necessary preoperative consultations have occurred. And consideration of patient and family needs given temporary relocation to placenta accreta spectrum center of excellence. Those people who come from villages, from neighborhood, they have to relocate to a center of excellence for this kind of nightmare surgery. Intraoperatively, we have to verify the appropriate complement of surgical expertise involved or available, or both. Intraoperative availability of resources to optimize each case as adequate surgical trays and necessary urologic and vascular equipment. Verification of availability of related services as necessary. Coordination of blood bank with scheduling or timing of case. And for the post-operative, assurance that critical care services are engaged and available for post-operative care. Preoperative assessment of physical examination with particular emphasis to neck mobility and possibility for difficult intubation. Hemodynamics measured. Discussion of lumbar epidural insertion with advantages at both intraoperative and postoperative levels. Less anesthetics, providing analgesia, early mobilization, and therefore this is the cornerstone in the ERAS or the enhanced recovery after surgery, and early return to PO. These women are given minor tranquilizers as Camipam the night before surgery, revision of any anticoagulant intake to be stopped at appropriate time, intravenous fluid plan given prior to induction of anesthesia is given 2 to 3 hours earlier to compensate for fasting hours. And as a part of ERAS, we usually give 200 mL of 10 to 12% dextrose just to have, to prevent the catabolism or to reduce the catabolism in the early postoperative period. Upon arrival to the operating theaters, a wide-bore peripheral intravenous line is established under local anesthesia and intravenous fluids restarted. In sitting position, lumbar epidural catheter is inserted. I usually prefer L23 space, tested and activating using local anesthetic. Usually this is 1/4 strength bupivacaine and fentanyl in a dose of 2 microgram per milliliter given a local anesthetic. Hemodynamic parameters are taken at frequent intervals for 10 to 15 minutes. Then the lady, all these things are done in the anesthesia room, not in the operating theater. Then the lady is transferred to the OR. Upon arrival, basic monitors are attached and denitrogenation using 100% oxygen. Hypnosis is achieved by sleeping dose of propofol, then saxamethonium 100 milligrams and intubation is achieved. After fading off the effects of saxamethonium, we give the non-rising muscle relaxant. Either we give atracurium or rocuronium according to what's available in the facility. Once intubated, mechanical ventilation is adjusted to maintain end tidal at 30 to 35 millimeters of mercury, and positioning of the patient in the left lateral position by putting a wedge under her right buttocks, and insertion of the central line into the right internal jugular vein under strict asepsis and triple lumen fixed at 13 to 15 centimeters from skin. We cannulate the radial artery in the non-dominant hand and after a negative modified Allen's test. Further intravenous lines insertion into the external jugular vein, cephalic, or any other vein that accommodates at least gauge 16. Maintenance of anesthesia can be achieved either using inhalational or more preferably, I preferably use intravenous anesthetics. I almost always use total intravenous anesthesia in this particular context. This because of the following. Using intravenous anesthetics will avoid me to give inhalation anesthetics, and the effects of inhalation anesthetics on the tone of the uterus. I usually run propofol in a dose of 80 microgram per kilogram per minute. That's about 5 milligram per kilogram per hour. And otherwise, we give end-tidal 1% isoflurane or 1.5% sevoflurane if other anesthesiologists are carrying out the case. And as regards propofol, what I give, this is about 1.3 MER. MER, I mean by MER is the minimum infusion rate, which is equivalent to MAC in inhalation anesthesia. And as I told, it has no negative impact on the uterine tone and taking the advantage of the epidural inserted and activated. Should intravenous anesthesia is given, then the use of muscle relaxants must run at fixed intervals or as infusion. Probably this is best fit with atracurium. Or if we give rocuronium, then I would rather prefer the use of peripheral nerve stimulator before giving any additional dose or top up. An initial blood gas, hemoglobin electrolytes are best done immediately after induction and used as a reference. What I would like to stress in my lecture is the fact that unlike the ordinary cesarean section, where we expect a blood loss less than 1100 mL and needs no intervention, the situation here is very different. The anesthesiologist must be aware that at a particular time, he may not be able to compensate for the massive blood loss over a few minutes. Therefore, it's mandatory that the anesthesiologist must stand ahead of the surgeon, replacing ml by ml and not waiting for the permissible 1000 mLs and taking into consideration the post-induction hemoglobin and hematocrit. The use of ecbolics appropriately as soon as the baby is delivered and monitoring the urine output, both volume and color, particularly when hysterectomy is planned. Don't hesitate to start inotropes to support the circulation. Should the mean blood pressure drops below 70 millimeters of mercury, and the one of choice we use is the norepinephrine, and we usually start in a dose of 0.05 to 0.1 mic per kilogram per minute. Might promptly replace blood loss by blood. This slide shows the blood products we use in case we face a massive hemorrhage. We give packed RBCs should the hematocrit drops below 18, and if the hematocrit is less than 30 in unstable patient or active bleeding. So we start at less than 30 or the equivalent of hemoglobin of less than 10 in unstable patient or active bleeding patient. The volume is usually 300 mL, and each unit would increase the hematocrit by 3%. As regards platelet, we give platelets should the platelet count drops below 50,000. Or there is microvascular bleeding with massive transfusion one-to-one with RBCs. The platelets is 50 mL and would increase, one unit would increase the platelet count by approximately 7,500 per cubic millimeter. The fresh frozen plasma we give should the INR is greater than 2, or the activated partial thromboplastin time is more than 1.5, or with massive transfusion with RBCs, the volume is 250 mL, and one unit would increase the fibrinogen by 15 milligram per deciliter. As regards to the cryoprecipitate, we give cryoprecipitate should the fibrinogen level drops below 100 milligram per deciliter. The volume is 40 mL, and this would increase the fibrinogen by 10 to 15 milligram per deciliter per unit. In all of these packed RBCs, platelets, fresh frozen plasma, or cryoprecipitate, we may face complications like human error, hemolytic reactions, infection, and transfusion-related acute lung injury. Now, in order to reduce the intraoperative blood loss, we recently carried out in the Department of Obstetrics in Kasr and Aini 3 studies. The 3 studies were completed, published in 2019 and 2020. These 3 studies carried by our surgical team led by Professor Hussein, and published that helped in the significant reduction of intraoperative blood loss, ICU admission rates, and the total hospital stay. These studies, the first study was a modified cesarean hysterectomy technique for management of cases of placenta accreta and percreta at a tertiary referral hospital in Egypt. The second one is the role of prophylactic internal iliac artery ligation in abnormally invasive placenta undergoing cesarean hysterectomy, a randomized controlled trial. And the last one that was published just last August was the role of ultrasound in prediction of intraoperative blood loss in cases of placenta accreta spectrum disorders. So with the first study, which is the modified cesarean hysterectomy, 63 cases with abnormally invasive placenta were enrolled. The technique entails devascularization of the uterus laterally on both sides and to clamp the uterus at the lowest possible point just below the level of the placenta while sparing the ureters. The difference between the pre and post-operative hemoglobin was just only 1 gram per deciliter, and the mean blood loss was 1,673 plus or minus 958 mLs. There was a significant drop in the post-operative need for blood and blood product replacement, packed RBCs, and plasma units. The operative time ranged 190 plus or minus 58 minutes, and the technique is slow and utilized meticulous hemostatic steps. ICU admission was just only 4.8%, with a mean total hospital stay of 8.6 plus or minus 3.6 days. In conclusion, this technique reduces maternal morbidity and mortality while performing cesarean hysterectomy for cases with abnormally invasive placenta. The second study done with the role of prophylactic internal iliac artery ligation that was published in 2019. In this study, 57 patients with abnormally invasive placenta were included randomly allocated into two groups. Bilateral internal iliac artery ligation, 29 patients, and control group who underwent cesarean hysterectomy only. And the results showed that there was no significant difference between groups regarding intraoperative blood loss, which was around 1,632 plus or minus 804 versus 1,698 plus or minus 1251 mLs, with a P of just 0.83, while there was a statistically significant increase in the operative time, which was 223 versus 171, with the p-value less than 0.001. In conclusion, bilateral internal iliac artery ligation in cases of abnormally implanted placenta undergoing cesarean hysterectomy is not recommended for routine practice to minimize blood loss intraoperatively. The last one that was published just a few months ago involved 50 women with placenta accreta. They were scanned the day before planned delivery, and hysterectomy for various sonographic markers indicative of placental invasion. Only the presence of numerous coherent vessels involving the bladder serosal interface was proven to be an independent predictor of major hemorrhage during hysterectomy. Therefore, in conclusion, the use of 2D color Doppler and 3D power Doppler can help predict massive hemorrhage in cases of placenta accreta spectrum disorders. This study in particular is very important should we find the coherent vessels involving the bladder serosal interface. This is an indication of the fact that the lady is going to bleed massively, and we have to prepare ourselves with the clinical hematology unit to supply us with extra units of blood. As regards to the post-operative considerations and management, placenta accreta spectrum patients require intensive hemodynamic monitoring in the early post-operative period. And this is best provided in an ICU setting to ensure hemodynamic and hemorrhagic stabilization. Close and frequent communication between the operative team and the immediate post-operative team is strongly encouraged. These patients are at particular risk of ongoing abdominopelvic bleeding, fluid overload from resuscitation, and other post-operative complications given the nature of the surgery, degree of blood loss, potential for multi-organ damage, and the need for supportive efforts. Going back home messages, placenta accreta is becoming increasingly common and is associated with significant morbidity and mortality. Knowledge of risk factors and antenatal imaging expertise can help guide the diagnosis. Preparation for delivery and postpartum care should involve a multidisciplinary team and early antepartum consultations guided by the levels of maternal care. Caesarean hysterectomy can be challenging and should be performed by the most experienced surgeons and anesthesiologists. Thank you.
Thank you so much, Dr. Tarek. You make it so simple and so nice and the less nightmare we have. Can I ask you, Dr. Tarek, what do you think about, from your clinical experience, the use of synthetic recombinant factor 7 or transaminic acid in some institution before the onset of severe bleeding?
Okay, the onset of severe bleeding, this is, with the placenta accreta, the vessels are massive. Bleeding mainly comes from the surgical fold. I mean, that's why the modified radical hysterectomy that's carried out, though takes much longer time, but there is devascularization. Definitely what you say as regards to recombinant factor 7, yes, it can help. But the most important is to prevent by an expert surgeon who can make your life much easier than making us in a bad situation. Okay. Tranexamic acid or recombinant factor 7. But again, these are very expensive tools. I mean, if you let the surgeon, if the surgeon is competent enough, we didn't use, I mean, I myself, I used to give anesthesia 1 to 3 cases a week over the last decade. So probably I passed 500-600 cases and no one ever needed to use this recombinant factor 7.
Okay, thank you, Dr. Tarek. We have some question. Is central, from Dr. Muhammad Sulaiman, is central line is mandatory?
Oh, yes, it's mandatory. It's mandatory because when you are in a trouble, then you have an already line. I can tell you at the beginning when we started giving anesthesia in these cases, I still remember one of my very first cases, I gave 26 units of ACT RBCs. So I think that's probably 4 times her blood volume. So, I mean, central line is mandatory. The invasive arterial line is mandatory.
Again, from Dr. Muhammad Sulaiman, is there any change in anesthesia plan if we are facing placenta accreta as an emergency case? And it does come, yani, in our duty, we have, sometimes they are pushing placenta accreta recently diagnosed in ER.
Okay, first of all, just we have to know before putting the woman into sleep. We have to know whether this is a straightforward cesarean section or it is a placenta accreta case. And this, I think, nowadays, it's a routine practice to do an ultrasonography, even if the lady is not regularly attending the antenatal care, but at least the moment she arrives to the hospital, then an ultrasound will definitely show the presence of an abnormal placenta. And in this case, this depends upon the nature of the urgency of the surgery. If it is life-saving, then okay, we have to go with all the risk. But if we have time, 1 or 2 hours, we can always arrange for blood. The most important item is to get blood. I think is this clear?
Okay. Dr. Tarek, is there still any role for uterine artery embolization prior to surgery?
It's not done in our facility. It's not done in our facility. Probably yes. I had a talk 2-3 times with Professor Eric Genot, who is a professor of obstetrics at London University, and he's the one who put the guidelines for placenta accreta. Still in UK, I think until now this is done very selective.
Okay, thank you so much, Professor Tarek. We are enjoying your lecture. You make our life more easy. Thanks so much.
Thank you so much. Thank you. Thank you.